All right, let's dive right into this medical mystery, fluid in the lungs, and transform you into a diagnostic detective with this fast-paced explainer. We're zeroing in on pleural effusions today. You know, when excess fluid pools up in the pleural cavity. Our goal? Decoding exactly what that fluid is screaming at us about a patient's health. Here is your diagnostic checklist for the shift. We're mapping out the chronological journey from first spotting the fluid to ultimately saving the patient. We'll kick things off with Transudate versus Exudate basics, crack Light's criteria, navigate the critical chest tube decision, uncover biochemical clues and causes, and then finish up with our rapid-fire high-yield exam review. So, first up, Transudate versus Exudate basics. Step 1 at our crime scene is immediate. We have to divide the fluid evidence into two distinct camps. The absolute crux here is contrasting bland, pressure-driven Transudate against angry, protein-rich Exudate to establish our baseline. Transudates, well, they're all about systemic pressure shifts. Think hydrostatic or oncotic imbalances, right? Congestive heart failure is the most common culprit, along with liver cirrhosis and nephrotic syndrome. On the flip side, exudates are driven by local inflammation or increased capillary permeability. We're talking pneumonia, malignancies, and TB. It's essentially the difference between a massive systemic plumbing backup and a localized inflammatory fire. Okay, moving right into cracking Light's criteria. Because let's be real, sometimes the fluid doesn't clearly fit into one box or the other. When pleural protein is sitting ambiguously between 25 and 35 grams per liter, we pull out our primary forensics tool to interrogate it. And this brings us to our first cheat code. Lock the number 5 into your brain. It's step 1 in the famous 5-6-2-3 mnemonic. If the pleural to serum protein ratio is greater than 0.5, boom, you have an exudate. Think about it. If that much protein is leaking into the pleural space compared to the blood, inflammation has clearly blown the floodgates wide open. Let's bump it up to the next threshold. A pleural to serum LDH ratio greater than 0.6 also locks in that exudates diagnosis. Now, LDH, or lactate dehydrogenase, is a classic marker of tissue breakdown. So if that ratio tips past 0.6, the local lung tissue is highly irritated, pointing a massive neon sign straight at an exudative process. Finally, the last piece of our 5-6-2-3 puzzle, pleural LDH greater than 2/3 the upper limit of normal serum LDH. Here's the kicker. If even just one of these 3 criteria is met, you are absolutely dealing with an exudate. It's an incredibly sensitive rule, designed specifically so we don't miss a sneaky underlying infection or malignancy. All right, on to the chest tube decision. We're raising the stakes now. When exactly does this fluid escalate into a clinical emergency that demands a chest tube? According to the BTS guidelines, there are mandatory chest tube criteria for parapneumonic effusions. You have to intervene if you hit any of these 4 steps. Step 1, the fluid looks frankly purulent. Step 2, the chemistry is dangerous, specifically a pH less than 7.20 or glucose dropping below 3.3. Step 3, microbiology comes back with a positive gram stain or culture. Or step 4, imaging shows loculated or septated fluid collections. If any of those red flags pop up, a simple needle aspiration just won't cut it. A drain is absolutely mandatory. Next up, biochemical clues and causes. You've just drawn the fluid, so let's head into the forensics lab and see exactly what villains these markers are pointing to. We use this forensic map to match some pretty bizarre clues directly to their culprits. Imagine drawing a milky white fluid that's just packed with triglycerides. That points straight to a chylothorax, usually from a disrupted thoracic duct. But what if it's heavily blood-stained? Your mind needs to instantly jump to malignancy, pulmonary infarction, or trauma. If you catch raised amylase on the panel, you should strongly suspect acute pancreatitis or an esophageal perforation, classic Boerhaave syndrome. And if complement levels are noticeably low, systemic lupus erythematosus is your prime suspect. Keep the TRAM mnemonic right in your back pocket. It is a brilliant anchor for instantly recalling the classic causes of low glucose. T is for tuberculosis. R is for rheumatoid arthritis, which is a super classic textbook finding. A is for abscess, or empyema, and M stands for malignancy. Basically, if glucose is less than 3.3, one of these heavy hitters is actively metabolically consuming it right there in the pleural space. All right, let's wrap this up with a high-yield exam review. I'm putting you in the hot seat with a rapid-fire clinical simulation using some top MSRA exam questions. Here's the setup. The clock is ticking in the ER. You have a patient with a parapneumonic effusion, and their pleural fluid pH is 7.12. The fluid might look completely clear to the naked eye, but that pH number is screaming at you. What is your immediate management step? Exactly. You insert a chest tube immediately. Knowing that pH 7.20 cutoff is completely non-negotiable. It formally defines a complicated parapneumonic effusion, which requires urgent drainage to prevent some really severe fibrotic complications down the line. Okay, let's jump to the next case and see how simple visual evidence can totally dictate our next move. Because sometimes you don't even need to wait for the biochemistry lab to call you back. What visually defines an empyema on a diagnostic pleural aspiration?
Right. The crucial point here is that seeing frank purulence instantly confirms an empyema. No lab required whatsoever. The exact moment you pull back on that syringe and see thick, purulent fluid, you've made your diagnosis and you know exactly what to do next.
Let's look at a much more dramatic presentation now. A patient rolls in after severe, repeated vomiting. This one is visceral and honestly pretty shocking. What fills the chest cavity when Boerhaave syndrome strikes? It's salivary amylase, flooding in from the ruptured esophagus. It's a wildly memorable biochemical red flag. Because the esophagus has actually torn, saliva and gastric contents spill directly into the mediastinum and pleural space, which drives those amylase levels absolutely through the roof. Finally, before you even think about inserting a needle or a tube into a patient's chest, what safety protocol is absolutely mandatory according to the guidelines? Thoracic ultrasound. It's your mandatory map to ensure you actually target the fluid and, avoid puncturing vital organs. Gone are the days of blind taps. You absolutely must visualize the fluid, check for those tricky loculations, and guide your needle safely. So you are now fully equipped to decode the clues hiding in plain sight. But I want to leave you with a final thought to take on your next shift. When you pull fluid from a patient's chest, you aren't just looking at a symptom. You are holding the master key to an entire systemic puzzle. The next time you see a chest X-ray with a total whiteout, ask yourself, are you just seeing fluid, or are you looking at the very first clue of a much bigger medical mystery?